has reflected much more sound waves towards your probe compared to the liver parenchyma. So that's how we could recognize that there is a lesion in the liver. This is the kidney, right kidney. It has different color, different density compared to the liver or compared to even to that lesion. So for us to recognize that there is a lesion in an normal structure, it's about that density, that hyperechoic, hypoechoic, anechoic, and from there you can know that this is a cystic mass, it's a solid mass, this is calcification. Yeah. So going to this one, this is also the liver, but within this image, can you see my cursor, my pointer? Can you?
Yes.
Aha. From this image now, even this is the liver. You can see the liver parenchyma here, but also you can see this tubular structure that are two black. They are black because who can tell me the reason why they are black? Who can tell me the reason why these structures are too dark, black? What's the difference between these black dark structures and the liver here? What's the difference? Why are they different?
It's an echoic.
It's anechoic. Very well. It's anechoic, meaning it has they have
Pure fluids.
fluid. Those are blood vessels. Exactly. Those are blood vessels. On ultrasound now, they are dark like this because they don't block, they don't reflect any sound waves. Compared to soft tissue that can allow some to pass, others to reflect, come back to the transducer, the probe. So you can get the difference. You can recognize some structures. Going to this, this is a 3D image of a fetus in the abdomen. Can you see how you can even recognize that the father and the son they look the same? Can you see the nose, the eyes, the ears, and even the mouth? Can you see? It's like this fetus is the abdomen, the uterus. This is a 3D ultrasound image. Going to this one up on the right side, you can see it's the fetus that is in the uterus, the abdomen, where you can see the head very well. If the skull is white because it is reflecting much sound waves. The brain is somehow dark because it doesn't reflect much. Some waves are continue going, and you can see the nose, the mouth, the spine behind, the neck, even the heart. Can you see the heart here? On real-time examination, you can see even the heart beating, can even measure the heart rate. You can see the hand. If the fingers, can you see 1, 2, 3, 4, 5 fingers? Very well. Even this is the leg. So ultrasound can show you, this is the dark one is fluid in the uterus. Fluid, stuck, it's anechoic. You see? That's a very good procedure. Coming down, this is now the head of the fetus with the content of the brain inside. I just wanted to show you how this is the cervix here. The cervix, the head is near the cervix, meaning the other part of the fetus are up there where I didn't scan. And for someone who asked me about posterior acoustic enhancement, can you see through the brain, because the brain can allow some sound wave to pass through it. Posterior to it, there is whitish here, increased whitish here. That is what we call posterior acoustic enhancement. Posterior acoustic enhancement. And from here, if I go back to this image, can you see those hypoechoic structures here? And posterior to it, there is that darkness here. That's what we call posterior acoustic shadowing, because these structures are reflecting much sound waves, and behind it now there is a shadow. That shadow is what you call posterior acoustic shadowing or shadow. And from there you can recognize this is that, this is that. All right. Going to this, the last image here, ultrasound. This is transcranial ultrasound, transfrontal ultrasound, where you see the brain, you see the ventricles. This is a no-net. This is the ventricles, posterior horns, the third ventricle, and you can see that always posterior to cystic, dark structure, cystic, there is whitish behind. That is posterior acoustic enhancement. Even here, because there is that ventricle here, posterior to it, there is enhancement of sound waves. Even here, enhancement sound waves, because in the third ventricle, there's some classification, even for the no-net classifications. Behind it, there is this darkness, this shadow. That's posterior acoustic shadowing or shadow. All right. So have you understood those terms? Hypoechoic, anechoic, posterior acoustic shadowing, a posterior acoustic enhancement. Now you understand them very well. All right. Is it clear?
There are some people who
Yeah.
now
No, we didn't.
we found we're done with the pictures. dusanze murangije gusobanura amashusho internet yari yanze.
Ikibazo cyawe ndakisetse kubera yuko niba watinze kandi saa munani zageze urabaza bagenzi bawe bari bahari bagusobanurire, nta kibazo. Izi note ndahinza ndazibahereza, you can go into them again and try to understand. Sibyo nta gitangaza, hari n'abandi bari buze nyuma yawe kandi sinasubiramo. It's better kubaza bari bahari kandi babyumvise, ahubwo bari bahari. Have you understood everything? Is it clear?
Question.
Yes.
I didn't understand about acoustic enhancement and acoustic shadowing.
Okay. Janet.
Yes, Prof.
Iyo kiza cyo kuba umuyobozi nicyo nyine, nicyo kibi nako ngira ngo. Try to answer the question. Explain to him.
Did he ask, like, I didn't understand where the question.
You can ask again.
I didn't get where the meaning of acoustic enhancement and acoustic shadowing.
Hey.
For the posterior acoustic enhancement is when the sound waves, they pass through the structure, which was like pure fluid, which is black, and then the structure which is behind it, it becomes very white.
Because sound waves have passed through it,
Yeah, they pass
and
through
have
it and
been concentrated behind,
They become the structure which is behind absorb the waves which pass through the
fluid content.
Yes. And then posterior acoustic shadowing is when the segment or the structure where the waves are going to pass through is white. Like, for example, like bone, because they block the waves. They doesn't pass through it. They become reflected. And then the structure behind it, it will become black because it will not absorb anything. The waves will not reach there. That is what we call stereoacoustic shadowing.
birasobanuye neza cyane
Cyangwa
twahura uzanyibutse ko ari wowe Jeannette
bivuge mu kinyarwanda sinzi niba byumvishe neza.
yabyumvise niba atabyumvise afite ikibazo
nabyumvise
okay nta kibazo ubwo nta kibazo ufite mufunge mic zanyu kugira ngo dukomeze. All right, let me go to next slide then. So hari cyane ahantu hose we have ultrasound machines and we use them in like a hospital. Main imaging procedures we do is that transvaginal ultrasound. The reason why we do transvaginal is when that interface of the probe can be near organ you want to see. When you are near the organ, the image becomes clearer and you can better diagnose the disease. That's the reason why we use this intraluminal scanning, ultrasound scanning. So like transvaginal, like transrectal, like transrectal for the prostate. Because if you introduce the probe into the rectum, you will be near the prostate and you will see it better. But when you pass on the pelvis, on the skin, on the pelvis, it may not be that clear so that you can even miss a disease. But also we can even do transesophageal, introduce now the probe into the esophagus, but we don't use it, we don't have it here in Rwanda. Transesophageal scan, when you want to see better the heart, like scanning the heart, pass through the esophagus and you be near the heart, you can see better in details. All right, like in the small heart defect. You can even do intraluminal scanning for staging tumors of the gastrointestinal tract or esophagus, so that you can be near, the interface of the probe can be near the tumor. You can even use intravascular scanning, but we don't do it here. We don't have those probes here in Rwanda. Even operative scanning, where you use ultrasound when you're operating something in the abdomen. You can use ultrasound to guide the surgeon where he's want to operate. So those are different ways to where I can use ultrasound. Okay. So the main indications for ultrasound examination now. The first one, like pregnancy. It helps in monitoring pregnancy and diagnose complications. It can help in diagnosing uterine or ovarian lesions, the disease of the liver, the spleen, pancreas, and even other abdominal organs, solid organs. It can show you the abdominal masses, not even mass peritoneum. It can help you to confirm if there is a pleural effusion or not, or pleural mass. Here I want to say that if you're suspecting a pleural effusion from chest X-ray, but you are not sure if is it pleural effusion, is it pleural thickening, before you go to X-ray again, you can, or CT scan, you can use ultrasound, because first of all, two advantages. Number one, the cost. Ultrasound is cheaper. Number two, there is no radiation. Number two, there's no radiation. And the number three, even it is accessible. You can even use it in the ward here, in the patient ward. So without even displacing the patient to radiology. So don't never want to confirm pleural effusion and send the patient for X-ray or CT scan. No, just use ultrasound. It is very easy, and you can even do it yourself without a radiologist or sonographer. You can see some gallbladder disease like gallstones or gallbladder tumors. You can see them very well on ultrasound. Urinary tract, kidneys, ureters, bladder, you can see them very well on ultrasound and see if there is any like renal stones, ureteric stone, or renal bladder tumor, even hematoma in the renal bladder. You can see them on ultrasound very well. Testicular tumors or testicular lesions, many different testicular torsion, varicocele, or any other hydrocele fluid in the testis, in the scrotum. You can see them very well on ultrasound. Neck masses, different masses on the neck. Using that linear probe, you can see them very well and know this is this is that. Even soft tissue lesions, you can see them very well. And if there is any suspicion of brain abnormalities, especially in neonate, because there is a window where to pass. So you can use ultrasound. We do, by the way, we do transfrontal ultrasound to see any abnormality in the brain. All right. So those are different indications of ultrasound. So there is something else we call Doppler ultrasound. Maybe you heard about it and haven't talked about it today. Doppler ultrasound is an ultrasound of the blood vessels where you can diagnose like thrombosis, like arteriomatous disease, where there are some plaques in the wall of the vessel, any stenosis. You can use a Doppler ultrasound. Doppler ultrasound is another technique of ultrasound where you can see the blood flowing. You can recognize this is a vein, this is a artery, and you recognize even them. And it's very you can even measure the velocity of that blood flow. The imaging of carotid arteries for arteriomatous disease, in the case of transient ischemic attacks. Those are Doppler ultrasound can do many things here. Okay, any question here? No question? Let me continue. So this is an example of this is an image of a Doppler ultrasound where they have magnified the image, but this is a vessel here. This is a vessel. They have put a color, though the color has changed, but normally it is either red color or green color or blue color. Sorry, red for arteries and the blue for veins normally. So from there you can recognize this is a vein. This is when you are confused, you can say, is it an artery? Is it a vein? And you can recognize and measure anything, velocity, resistive index, many things you can measure from there. You see it when you come for rotation in radiology. Okay. So advantages of ultrasound. First of all, the cost is very low. It's accessible. It's available everywhere. In hospital, you have them in internal medicine, radiology, emergency, you have ultrasound machines. It doesn't use ionizing radiation, I have told you. It's very safe. It's very portable. You can displace the machine instead of displacing the patient to come to radiology. You can displace the machine, found the patient where he is. It can scan in any plane, any transverse, sagittal. Put the probe behind on the back, wherever you want to see. You can go there and see it. And another one, it can even help in doing biopsies or doing drainage of some masses, some fluid cystic masses. So, it is called ultrasound guided biopsy. So the advantage is it cannot, I told you, it cannot penetrate bones or gas. Bones and gas are enemies of ultrasound. So when you want to see a disease of the bone or in the stomach, don't think you can use ultrasound and see well the region there. And number two, it's very operator dependent, user dependent, I told you. So meaning all the reports you get from the clinic when you send patient for ultrasound, don't believe them at 100%. It depends on who has done it. So you have to use your clinical knowledge say, is it really true? Or it doesn't really correspond to what I have seen. And even go there and discuss with the operator. And again, it is because it is being available, ultrasound being available, it is on one side, it is something good. On another side, it has a drawback because people have started misusing it. Everybody is just doing scan. You remember, it doesn't have any radiation, ionizing radiation. It's safe. People are misusing it and doing ultrasound and deciding about the diagnosis, which can lead to errors in diagnosis. So that one you will see when you start practicing medicine. So it has two sides. And again, for people who are very obese, they are really enemies. They are not friends of ultrasound, because you remember, as you have a big the thickness of the body you are scanning, it can degrade the image quality because of the scatter. I've explained about scatter. So this one you have to know. By the way, this is for you, because you have to know them so that when you are practicing medicine, you know how to decide. For a very obese patient, you can even decide not to do ultrasound, but to do CT scan instead. All right. Okay. So we are done with ultrasound. Remember, this lecture is about overview of medical imaging. What's being done there? What do we have? How can you select? I want to do this and this and that. Okay. So we go now to nuclear medicine. We don't have nuclear medicine in Rwanda, but it happens. Sometimes we send patients outside the country for nuclear imaging. Why? First of all, people, they call it nuclear imaging. They can call it radionuclide imaging, or even scintigraphy, or even nuclear scans. So all of those names are for nuclear medicine. So how do they work now? First of all, you don't use X-rays, but they use gamma rays. Remember, electromagnetic energy has a very large spectrum. You remember the slide I showed you. So this nuclear imaging now, they use energy called gamma rays, the gamma rays. But also these gamma rays, they have ionizing radiation. All right. The difference between the nuclear medicine and other modalities we have seen already is that for nuclear medicine, we don't, the energy, the X-rays, they don't come from out the machine to the patient. But here it is opposite. That X-rays are coming from the patient to the machine. Why? You can either inject those substances we use, they are called radionuclides or radiopharmaceutical. We can either inject in a vessel, in a vein, or swallow it, or even inhale it. Now, when that substance is in the body, you put the patient in the machine. As those substances are decaying now, they decay with time. Now, they can produce some energy going into the machine, and now the machine can recognize now where is the problem. Can you get it? Do you understand the difference between? Yes. Hano mwumve itandukaniro nuko ku yandi modalities twabonye ya X-ray nuko hano that energy called gamma X-rays, they don't come from the machine to the patient, where ahubwo babitera mu murwayi, none umurwayi yaje kuri machine, sibyo, uko haba decaying, iriya substance igenda itakaza umwimerere wayo, ikagenda isohora ama energy ajya muri machine. Noneho bitewe naho yageze, hariho ashinzwe kujya muri thyroid, harimo ashinzwe kujya mu gifu cyangwa muri GI, harimo ashinzwe kujya muri bones. Uko agenda decayinga, wayamuteye cyangwa se yayanyoye cyangwa se yayahumetse, akagenda uko bisohoka mu mubiri w'umuntu, mashini ikabidetectinga, ikabasha gutanga image ivuga ati mu gifu hararwaye, muri thyroid hari spot, hari ahantu harwaye, hari akabyimba. That's how it works. And from there are two terms we use in nuclear medicine. We use hot spot when there is an area of increased tracer uptake, increased sub-energy uptake. We call it tracer uptake. When it has, there is an area of increased tracer uptake, that we call hot spot. When there is no, it is decreased now. See the, murabyumva? Ko mwabicomoye, murabyumva neza?
Yes.
Yes.
Could you hear it?
Hot spot and a cold spot in organ like thyroid, you have given a radionuclide for the thyroid specifically. It goes there, but there is a focal area where there is no uptake, and the rest of the organ, the rest of the organ, it has taken some radionuclide tracer, but some focal area there is no uptake at all. That's called cold spot. And from those two terms, we can, from radiology, you can recognize, because it is hot spot, it is most likely this disease. Because it is cold spot, it is most likely this disease. Okay? Birumvikana ariko. Yes. Birumvikana.
Yes.
Nimushatse kubyumva nkuko mbyumva jewe, ibyinshi muzabyumva mwaje muri rotation. Ariko, I want you just to know, at least to have an idea about what's going on in radiology. So we have different now scans in nuclear medicine. For bone scans, we call it scintigraphy. But you have also SPECT imaging, what's a single photon emission computed tomography. There is what we call PET. Maybe you have ever heard about it. Positron emission tomography. They work differently. Or we can even combine PET and CT scan. CT scan for anatomy, PET for functioning. Normally, nuclear medicine is about functioning of organs, functionality. It is not for anatomy. That's the reason why you combine sometimes PET scan. For people who have, we are suspecting a cancer or metastasis in the body, where CT, MRI cannot see, we can send them for PET CT scan, where the PET will be for detecting where there is a lesion, but CT scan will now show the anatomy as we see it in CT scan. Combine that, can give more information. For thyroid scan, we have it, but we have even another one called the Moga scans, Garam scans for thyroid scan. So those are different scans. They work differently, but the principle is the same. Some energy is coming from the body, going to the machine, detected by the machine, and you can recognize a disease from there. All right?
Question.
Mm-hmm.
Question ngize, ese part ifite ikibazo niyo ikora
No, I'm just joking. No. Nakubwiye ko aribyo bita hot spot na cold spot. Umva neza aho nta freeze up is. It's also cold spot where there is no uptake, but it means that there is, but they know what is going on. Okay. Example of
thank you.
Of nuclear imaging. These images are for on scan, and from there you can, where there is either hot spot or cold spot, and say, This is not asymmetrical. This is normal. There is a reason why there is a hot spot. Increase uptake, symmetrical is okay. But when you check everywhere, you check you can see like here, there is something wrong. Is it in its scrotum? Maybe the hot spot here, it's not on the left side. Maybe the all right. All right. Let's come down to the legs. Wait. Before you ask the question, let us come down to the legs. You see at the level of the ankle joint. Look, there is up here. The patient, you can say, you front, this is from that's the same patient, but if they have scanned where the patient down or abdomen. And those hot spots here and you know from during the how you can This advantage is in an organ is functioning mostly still. So, like I give an example for like pulmonary embolism. Pulmonary embolism, there is a scan called ventilation perfusion. You give a patient a nucleide in the vein, and another one is the patient can have that different one. When in the area where it is not symmetrical, maybe the contrast has gone there, but from the now the nothing going there, you say, this means something. This very expensive and difficult. Those the it's very, it requires some very expensive infrastructure. Those are limitations. Why we even have them in different places. We have a few. Ikibazo clinical imaging mbere yuko njya kuri MRI. Any question before I go to MRI? About that. It's normally called resonance imaging, magnetic resonance. So it's for MRI. Like CT scan, MRI is a cross same imaging. It uses, but MRI uses strong magnet instead of radiation. Okay, that's very important. Right? For about ionizing radiation, MRI is safe. And MRI creates pictures of, it's better in the monitoring of disease. MRI of the brain here. You can see some area dark, other white, and from darkness and white, according to which sequences you have used, guess which one is which one. All right. This another, like this is T1 of the brain, axial T1, where white, this white, it's white matter, and gray is gray matter in T1. Anatomy is far better than for CT scan. This what you find out layer, it's another sequence. So better in a small lesion than this. This is another sagittal T1 where you can recognize this and this is ventricles. Any small lesion you can detect on MRI than CT scan or other modalities. Okay. So advantages of MRI then. The main advantages are this one. Number one is excellent soft tissue contrast. Arikibazo?
Yes.
Iyo munafunguye microphone mtamva ko ari ikibazo. Can you ask?
We want to know about the colors identification.
Because I don't want to go into because first of all, it is very complex for you. Secondly, as you
Okay.
You cannot even understand it. You change the sequences for you to analyze any structure in the body. That's how machine functions. You change the sequence, what you call sequences, the way machine works, so that you can recognize anything. Hello, doctor. Yes, ndi mu ishuri kereka niba byihutirwa yaba uyu muntu mukuru ariko yego no, we don't even have kids these days. Ntabwo dufite ama kids umwohereza kuri Faisal. Nduva mu Rwanda nta Kigali nta handi. Yego sawa. Sawa, sorry. So ikindi excellent soft tissue. Number 2, as city has some by modern, even MRI has motion artifact, but also for and the MRI doesn't have much artifact. Like that's the reason why if you suspect any lesion in the posterior fossa in the brain, because there are those. Number 3, it has multiplanar capabilities. When you are scanning in MRI, it immediately gives you coronal, axial. CT scan, remember, we only do axial scan, and afterwards we can reconstruct and now produce sagittal and coronal. So that's what we call multiplanar capabilities for MRI. Number 4, it doesn't have ionizing radiation. That one you know. Use magnet. Number 5, it is the imaging modality of choice for most brain and spine disorders, comparing to CT scan and other modalities. And it has high sensitivity in bone marrow, not bone cortex, bone marrow disease. Remember that CT scan is very good in bones, scanning bones, but for bone marrow, MRI is better than CT or any other modality because it has excellent contrast resolution, especially for soft tissues. Okay? Ibintu ntibyumvikana koko kuri level yanyu ibyo mushaka birumvikana pe. Good, Imana ishimwe. So limitations. Number 1, murayizi ni cost. Mu Rwanda so far we have in Kigali we have like let me see, 1 there, 2, 3. We have only 3 MRI machines. I think FISO and 2 in private hospitals. You know that already, because MRI machines are very expensive. Even for buying, even for maintaining. MRI is contraindicated in patients with cardiac pacemaker. Any other metal structure and metal component in the body, MRI is contraindicated because it uses magnet. But these days, from some years, by the way, you are no longer using any metal for like surgery or something. We use material compatible with MRI. Yeah, that contraindication was some years back, but now they have changed. Said now we are not going to limit this patient to do MRI in the future. We are using now those material compatible with MRI mostly at 99%. Something else as a limitation, it is decreased sensitivity in detecting small amount of calcifications. But CT scan is very well in detecting calcification, but MRI, and even small hemorrhages, MRI is not that good. If you are associating any hemorrhage or any calcification in the brain or somewhere else, it's better you use a CT than MRI. CT is still the imaging of choice for subarachnoid hemorrhage, a very small amount, and even for acute head injury. it's better use CT scan. If someone has injury, with 100% use CT scan than MRI. You cannot just send MRI for someone who had injury, head trauma or something. Another limitation is that, sorry, yes, Kenneth. Tell me, Ego. Anyway. Yes, nimeshuri niweze kumamagaranya. Sivyo. Ikindi, another limitation is bone details. If you are suspecting any bone tumor, any bone tumor, not bone marrow, bone tumor or something, it's better use CT scan than MRI. And artifact, even if I said CT has more artifact than MRI, but even MRI has artifacts. So that's another, it is a limitation for almost all imaging modalities. Another one, what I have experienced myself, not as me as patient, but from patient, is claustrophobia. People, they fear to go into MRI machine. Many people, they refuse to do the scan because of claustrophobia. Because it is a very small machine where you go in and spend some time, 30 minutes in. People, they fear it. They fear completely, say, no, really, let me go and die. I will not do this MRI. And the last one about noise. MRIs have noise. A lot of noise. Sincerely, you can say, remove from this machine before even the scan is finished. All right. Those are the of MRI. So I'm done with MRI. Any question?
No, I was just asking myself, what are the artifacts? You have said the MRI doesn't being hindered by bone, which can be some artifacts which may limit the quality of this successful MRI.
Artifact.
Yes, other than those, you say, I have seen that the bone is not artifact for this MRI. What can be the artifact for them?
Like motion, as remember the most frequent one is motion. Remember, spinning the machine, it is not easy. 30 minutes, 40 minutes in the machine, lying in the bed within a very small tunnel, and you don't move for 30 minutes. It's not easy. So it's the most frequent one. In intervention radiology, we do drainage procedures. We do vascular therapies, like in angioplasty, where we are dilating a vessel when there is a stenosis, or we are just injecting some medication for what you call vascular embolization, like there is a tumor somewhere, and you send some product into the vessel to go and now block a vessel supplying that tumor. And after some time, the tumor will shrink. That's called vascular embolization. What we call percutaneous chemotherapy through the skin. You give some chemotherapy, percutaneous thrombolysis. There's a thrombus somewhere, and you go in and you can destroy that thrombus. So those are the procedures we do in interventional radiology. By the way, we have interventional radiologists in Rwanda so far. We got one very recently, so we are very lucky. For these last years, we didn't have any. We can even do hepatobiliary intervention. Hepatobiliary intervention. We can even do percutaneous biliary drainage. We can do a gallstone removal, removing the stones without opening the abdomen. We can do what you call TIPS, meaning transjugular into the liver when the liver has a disease. We can do what you call percutaneous cholecystectomy. We can do genitourinary interventions, different ones. They are different. We do nephrostomy. Those are interventional radiology procedures. Interventional radiological procedures, and at least you have an idea. Intervention stenting, like on this left image here, on the image on the left side, can you see that it doesn't continue? And now interventional radiologist has gone in and put a stent and has dilated that vessel. Now the vessel is patent, it can work, and that stent will remain inside, and now the vessel will work as normal. Okay, comparing this, the left and this one, they are different. This is very patent, but there is a stent inside, but this one is blocked, stenosed. So that vascular intervention. Those are the stents. Even if they have magnified them, that's how the stents look like. The ones they send, they put into the vessel to dilate it when there is vascular stenosis. Okay? So, some questions? Before I go to another, there is another small lecture I want to give you before you go. We'll call it a day. Any question? Tell me. Any question? No. No question. Nizere ko mwumvise bino bintu tuvuganye. No question. Abubakar.
Hello.
Abubakar. Where is Abubakar?
Hello.
Tell me. Tell me. So from Mugabe, Abubakar, are you there?
Yeah, there.
So everything is okay? Nta kibazo mufite from side, that Gako side?
No question.
From Huye, Janet, Sepin. Janet, hari ikibazo? Any question? Listen.
I had this.
Uramutse usohotse aho uri. Do you know the objective of this lecture? It is like after this lecture and ugasohoka hanze ugahura n'umunyamakuru wa Radio Rwanda akubaza ati mbwira rero ibyo bintu mwumva byo muri medicine bita radiology ni ibiki, wamubwira neza ukamubwira uti rwose kankusobanurira, ukamubwira radiology ni ibi akamaro kayo naka ikora gutya, dufite modalities n'izi zitandukanye hana
Yego
wamubwira akagira isoni.
twamubwira.
Voilà, that was the objective of this lecture. tugiye ku kindi kintu rero ari iki ngiki rero ni gatoya cyane ntabwo ari kanini mu kanya turaba tukarangije. Okay, I need you to know what is radiation risk and radiation protection. Ndabizi neza ko umuganga agomba kumenya ibingibi mbere yuko ajya mu gukora akazi, kuko abantu benshi babyibazaho radiation risk niki, radiation protection, what's that? Ni ryari umuntu agomba kwirinda kujya muri radiology. Hari abaganga batinya kuza muri radiology batazi ibingibi, akavuga ati harasi najeyewe ntazapfira hari, just bypassing there, bira ntabwo najyeyo, cyangwa akaba yakohereza abarwayi kenshi inshuro ebyiri mu munsi bamukorera chest x-ray agasubiza inshuro ya kabiri ya gatatu. You know, uwo muntu adafite knowledge kuri radiation risk and radiation protection. So this is a very important lecture I like to give a student. Bakabimenya ukagira idea and you will know how to work properly. Sawa? Nibyo tugiye kurebera hamwe rero. Sawa? Okay? So there are some questions about radiation risk from imaging tests. That's what I'm going to talk about. Radiation can cause, in large doses, when you give a lot of X-ray to patient, that radiation can cause serious tissue damage. And that can increase a person's risk and even later developing cancer. That's one, large doses. But also doses of radiation, amount of radiation, but for a longer time, for years, very small amount of radiation. That also can be harmful, can cause cancer rate after it, have consequences differently. In number one, you receive a lot of radiation doses. And number two, a low doses of radiation. Both are harmful. So we are going to see now to answer some questions, common questions people can have about radiation risk linked with imaging tests. That's what we are going to do. Number one, this is a diagram trying to show that ionizing radiation can cause a problem anywhere in the body. Anywhere in the body. But there are some organs that are more sensitive than others. And even other factors, they are like age of the patient, which organ with a lot of mutation has a high risk of risk than other organs. So in the body, like thyroid, like gonads, like white blood cells, because they are multiplying every time, they have high sensitivity compared to other organs in the body. Okay. So how much radiation is the average person exposed to in a day-to-day life now? We are not, we don't receive radiation from just imaging, from radiology only. We are constantly exposed to radiation from a number of sources, including radioactive material in our environment, like radon gases. Radon gas. Do you know what is radon gas? Radon is a radioactive gas that forms naturally when, like, uranium, thorium, or radium, which are radioactive metals, break down in rocks or from soil or from groundwater. So those environment area, they can produce those radioactive material. We can even have radiation, ionizing radiation from cosmic rays from outer space. So all of these sources, they are called background, they cause what we call background radiation. And everybody is exposed to those radiations, background radiation. And it can vary from one country to another. There are some countries that have those radon gases, cosmic rays than other, especially those countries with high altitude. They have a lot of those sources. And from the study done in America, we didn't have any study here about the quantity of background exposure we have. But average is about 3. We use count and that is okay. But much of exposure from radon as aid in natural gas, which that vary from one part to another stage. So now atmosphere blocks and cosmic rays. Being at high altitude, as I stated, increases the person exposure to radiation. High altitude increases a person's exposure to cosmic radiation. For example, some people live in the higher part of the, they said, high altitude. They high altitude to radiation exposure than someone who is not traveling. So there are different sources of radiation. The most important one everywhere, it is those radon natural internal exposure. That is exposed to be 43%. The number one, it is medical exposure, radiology now, 20%. Number 3 is cosmic rays. We are all exposed to 13%. Number 4, it's Earth gamma radiation, 15%. Okay, now that was number 3, and number 4 cosmic, and number 5 other all man-made sources, 1%. Food and water, 8%. You know, there are different sources of radiation. So we are exposed to radiation, not just medical exposure. Okay, medical exposure is just 20%, but 80% is from now the environment. It's background exposure. So how much does an imaging test, now we come from background exposure, we go for imaging medical exposure now. We know that because we count how much radiation we are sending to patient, it's calculated, it is measured, it is not much radiation, but it depends on the imaging test used. CT scan, if you compare CT and the conventional radiography and nuclear imaging, they don't expose patient to the same level of radiation. For example, a single chest X-ray exposes the patient to about 1.0 millisievert, which is about the radiation dose people are exposed to naturally over the course of about 10 days. Uramutse ukoze chest X-ray imwe, you are exposed to radiation as someone has the background exposure of 10 days. That's what I mean. A mammogram or mammography exposed a woman or even a man of about 7 weeks of background exposure. You see? Some other imaging tests have high exposure. For example, a lower GI cells, like barium enema, barium nil, barium follow through, they can expose a person to about 8 now. It is no longer 0 point something, 8 millisievert. It's a lot. A CT scan of the abdomen or pelvis can expose the patient to 10 millisievert. That can go up to 20 millisievert if the test is done twice. Remember, when you do like a CT scan of the abdomen, we don't just do one scan. We do one scan without contrast. When we give contrast, we do another one, and we do another one for arterial phase, for venous phase, for delayed phase, like 4 times scan. Imagine now you are exposing the patient much more, up to 20 millisievert in one scan. Imagine. Okay. A CT coronography for the colon can expose the patient to 10 millisievert of radiation. But what after this, even if it is 10, 0 point something, the secret behind, the message behind is just keep in mind that these are just estimates, and studies have found that the amount of radiation you get can vary a great deal. But what I want to give as advice is this, is get only the imaging tests that are needed and try to limit your exposure to all forms of radiation or to shield the unexamined part of the body. When you are, for example, especially for more sensitive patient, we tend to protect the sensitive parts. We shield the sensitive parts so that they cannot receive radiation and cause any problem. So that's the message. For you, the message I want to give in this red color is this. When you are going to send a patient for imaging modality, think twice if there is any other option or not. Think, is it really necessary or it is not? So before you even decide to say, I want to request for chest radiograph, can you diagnose that disease without even imaging? If yes, don't expose the patient to radiation then. Or between chest X-ray and CT scan, can chest X-ray diagnose a disease? Yes. If it's yes now, don't send it to CT scan. Don't expose the patient for radiation. Sorry. So that's the message. So after being exposed to radiation, what happens in the body then? That's very important. People think of biological effect in terms of effect of radiation in living cells. But normally, ionizing radiation, it is interaction with atoms by process called ionization. Ionization, actually, it is interaction of X-rays with atoms. That's to say ionizing radiation. Interaction with X-rays with atoms. So all biological damage effect begin with the consequences of radiation interactions with the atoms that are forming the cells. As a result, radiation effect on humans proceed from the lowest to the highest levels as noted in the list below. Which list is this one? From down there, the radiation can expose the whole body. As you are scanning the whole body, you are scanning the chest, which may now affect the organ within the chest. That organ may affect now the tissues in that organ. And that tissue can affect the cells within it. And the cells can affect the molecules. And even the molecules can go and affect the atoms. That's how it happens. So from the whole body, organs, tissues, cells, molecules, and atoms. And that at the level of atoms now, it's where now the effect happens. It's where now the cancer will come in. All right? So there are two mechanisms now by which radiation can affect cells, either direct or indirect effect. Can have direct effect or indirect effect. Direct effect is when, direct effect is when the radiation goes directly into the atoms. Now, if radiation interacts with the atoms of the DNA molecule, that's how we call it. We call it now direct effect. That interaction may affect the ability of the cell to reproduce and then to survive. If enough atoms are affected, such that the chromosomes don't replicate properly, or if there is a significant alteration in the information carried by the DNA molecule, then the cell may be destroyed by direct interference with its life-sustaining system. So what Mavju is the direct system here, direct effect of the radiation. And now indirect now, it's when there is interaction of radiation with the component of the cells. Like you remember that our body at 70% is composed by water. Now the radiation now is interaction with the water in the body. But within the water, there are some other component that can be destroyed and cause what you call hydroxyls. And those hydroxyls will go and damage their atoms and DNA. And they can combine and form toxic substances, which can indirectly cause the cancer. All right? Since who can tell me? Janet. Janet, ara?
Yego, Prof.
Ngaho mbwira rero itandukanye direct effect and indirect effect of atom of radiation. Uko wavyumvise?
Neza kuri direct effect haba affected the atoms zikoze DNA molecules ku buryo
directly the radiation goes there directly
to the DNA rumva it's changing and habaho alterations za DNA molecules.
Yego.
Hanyuma for indirect effect tubwiye ko affecting the cell, like component of the cell, not directly to the nyine ntabwo itigera kuri DNA ahubwo.
It is changing the component, yes, the component which indirectly will go time and change everything, and it goes to DNA afterwards.
Yego.
That is indirect. Wavyumvise? Wowe wavyumvise na nizere ko n'abandi wavyumvise. Okay? So, as I have told you that some organs are more sensitive than others to radiation, like lymphocytes and blood-forming cells are more sensitive than other organs. Reproductive and gastrointestinal cells are also sensitive. The nerves and the muscles are less sensitive compared to those others. So, so that when you are exposing a patient to radiation, you have to think about this. Because who can tell me the reason why lymphocytes and blood-forming cells are more sensitive than nerves and muscles? Who can tell me? Abubakar. Abubakar? Yes. Abubakar. Nambwire, muranyisha kuri online teaching. Tell me. Iyo niyo ngaruka yo kwigisha online. Yaba nakureba ndebe uko umeze. Abubakar?
Hello.
Uranyumva se?
Amagana Abubakar.
Can you hear me?
Yes.
Oh my God.
Tell me why lymphocytes and blood forming cells are more sensitive. What do you think than nerves and muscle cells?
Because radiations usually targets highly active cells.
Highly
Active cells, including cancer cells.
active cells.
Highly reproductive, they
Cells.
have high mitotic rate. Yes.
Okay. Yeah, that's the answer, by the way. Okay,
Yeah,
that's
so
good.
the lymphocyte and blood forming cells are also highly active. So radiations will not be selective. They will be killing both cancer cells and the lymphocytes.
Yes. How
And
about
blood
nerves
forming
and
cells.
muscles?
So nerves and muscles usually are not highly active. Like nerves are stuck in in interface, so they don't have a high mitotic rate like those blood
Exactly.
forming.
Very good. Mumurankurikira neza cyane. That's good. Twagiye rero.
Yes.
Listen. Any question? No. Not all living cells are equally sensitive to radiation. That's what you know. Those cells which are actively producing are more sensitive than those which are not. That's what you have said. This is because dividing cells require collect DNA information in order to the cell's offspring to survive. That's good. A direct interaction of radiation with an active cell could result in the death or mutation of the cell, whereas a direct interaction with the DNA of a dormant cell, as well as cells and nerves, the muscle cells and nerves, would have less of an effect. As a result now, living cells can be classified according to their rate of reproduction, which also indicate their relative sensitivity to radiation. That one is very clear. This means that different cell systems have different sensitivities. Lymphocytes, white blood cells, and cells which produce blood are constantly regenerating and are therefore the most sensitive. Reproductive and gastrointestinal cells are not regenerating as quickly as less sensitive and are less sensitive. The nerve and the muscle cells are the slowest to regenerate and are the least sensitive cells. It was just a text trying to explain the previous slide. So this one, it's about whole body sensitivity factors, the factors for the whole body sensitivity. The factors, number one is the total dose. How much dose have you sent to the patient? How much dose the patient or the person has been exposed to? That's number one factor. Number two, type of cell. That's what you have said already. Is it a highly active cell or not? Number three is about type of radiation. Type of radiation. X-ray, convention, CT, nuclear imaging, they have different level of radiation. Number four is about age of individual. Seriously, the children, young patients, they are more sensitive to radiation than adults. Ibyo murabyumva neza kubera impamvu muzi. Number five, is about stage of cell division. Pregnancy, when a patient is pregnant, there is a time during the pregnancy where you can say, no, don't try to do a CT scan of this. But later on, at the end of pregnancy, say, no, there is nothing, there is no much cell division. So you can do CT scan of this patient, pregnant patient, Number six, part of the body exposed. I told you some organs are more sensitive than others, gonads, thyroid, even lens in the eye. They are more sensitive than other organs. general status of health. Like a very sick patient is more exposed than someone who is healthy. Tissue volume exposed. As the volume is much volume, you have more exposure than a small part of the body. That's the reason why when you are doing our scanning in radiology, we try to limit the volume of the body we are scanning. If it is about the breast, for example, make sure you expose that breast. Don't expose the whole chest, imagine. And again, the last one is about time interval over which dose received. That's for you. Don't sit in your clinic and send your kid or your patient for chest X-ray. In the evening, you send it again. Tomorrow, you send it again to see if the disease is healed or not. Tomorrow evening, you send it again. No, please. That time interval can play a role in the effect of radiation to the patient. So those are the factors you should know and consider when you are doing medicine about radiation risk. Hano karumvikana neza? Yego. Mwabyumvise? Twagiye.
Yes.
Twagiye rero. I told you about anger ntabwo ndi bujye mu bintu byinshi. I have already said about this. The effect of radiation considering the high doses and the low doses. High doses exposure, it has acute effect. It can burn even the body. You can see it immediately because of that high dose of radiation. But for low doses, this is for us who work in radiology. We can keep receiving very small amount of radiation for years and years, and they have the same effect. They cause cancer. After 10 years, you think maybe you are not receiving much, you're receiving a small amount of radiation. There is nothing you can see with your eyes. There is nothing happens. While, sincerely speaking, something is happening in your body. For those high doses, there is what you call acute radiation syndrome. It happens. Immediately you see the effect of radiation immediately, or in a few days. You see it on the body with your eyes. But for low doses, you don't see it at all. It can have an effect after years. That's what I wanted you to hear. But always remember this. There is what you call linear and non-threshold model of radiation risk. Linear means in increase in dose results in a proportional increase in risk. That's linear risk factor, radiation risk, linear. As you increase in dose of radiation, you are proportionally increasing the risk of the radiation. Non-threshold means any dose, even if it is small, no matter how small, imagine, can produce some risk after some long time. Those are two things you have to remember. Ibi ngibi birareba cyane n'abantu bo muri radiology cyane bakoramo bahora bari exposed kuri radiation nkeya bakibwira ko ari amahoro ko ntabwo igeze babona bahiye. There was no burn, there was no pain. Everything is fine. But they are receiving non-threshold radiation risk. Okay. Another term to characterize the radiation is about two things. Number one is about deterministic radiation. Another one is stochastic effect. Deterministic effect means a large amount of radiation can have a proportional amount of risk. Stochastic, as you're receiving very few amount of radiation, it can have effect after a long time. The same, they are meaning the same. Deterministics about amount of radiation you have received, that is proportional to effect, but stochastic effect, very few for long time cause the same. Okay, very clear. Ahangaha ndasimbutse n'aha ndasimbutse muzabisomera. Sinzi ko mwabibonye, nasimbutse kuri aho basobanurira kuri deterministic effect kuko nabisobanuye, simbutse aho bavuga kuri stochastic effect kandi nibira nababwiye nyine, hanyuma I go to this one. How to reduce radiation risk niho tugezeho. Niki wakora rero? How can you protect yourself from radiation? From medical radiation exposure, you have to know this. You have to use what you call appropriate justification for ordering and performing each procedure. Appropriate justification. Is it really necessary to do this scan to this patient? Can we treat this patient without imaging? Can we? If you can, don't send the patient to radiation. And those are two things: appropriate justification and careful optimization. Careful optimization is for us in radiology. Make sure you don't give much radiation to patient while you can use less radiation and produce the same image. It can happen. I can send a lot of even the machine, the setting of the machine can be sending a lot of X-ray without any added value. That's what we call careful optimization and appropriate justification, especially for clinician. Careful optimization for us now in radiology. Okay. From here, what I can say is this: each patient should get the right imaging exam at the right time with the right radiation dose. Birimo biriya bintu nicyo kintu nababwira. Buri murwayi wese use the right imaging exam. Is it CT, ultrasound, MRI? At the right time. Don't just sending patient. And use in radiology, let us use the right radiation dose. Let us be careful about the dose we are sending to the patient. Okay? That's how we can minimize or can reduce radiation risk to patient to us. Okay? So, there is what you call in radiology RR principle. RR meaning as low as reasonably achievable. That this RR, everybody who works in radiology knows this RR principle, as low as reasonably achievable. Please give low dose of radiation, and you get the best image you want, as RR principle. So that means each exposure should be justified on a case-by-case basis. Each exposure has to be justified. That's one. Number two, try to minimize the number of X-rays taken. Don't be careless so that you produce a bad image for you to repeat the same image. It happens where a technician, a radiographer, give you an image and say, no, this is very bad. I can't report it. Go and repeat. Please minimize the repeat of X-rays. Number three, try to minimize fluoroscopic screening time. When you are doing fluoroscopy, remember fluoroscopy, it is a lead time examination where you can continue scanning. No. Please try to minimize that time, screening time, so that you don't expose much radiation to patient. Number four, you have to focus beam accurately to the area of interest. That's what you call a collimation in radiology. Before you do chest X-ray, make sure you didn't go beyond the area of interest. With collimation, there is a lamp, there is a light on the X-ray machine that shows you that you have to stop by here. Don't go beyond this area. Okay. Number 5 or 6, only trained personnel should operate equipment. There's even a policy. A trained personnel It's the only one that can operate the machine. Number 6 or 7, minimize use of mobile equipment. Mobile equipment you have sometimes in the hospital, you have what you call mobile X-ray machine, where you move the machine from radiology and you go to ICU where the patient cannot move, and you expose the patient you want to expose. But by exposing that patient, you are also exposing other patient in the room. So minimize that. Number 7, use ultrasound whenever possible. Ultrasound or MRI. Ultrasound cheaper, MRI expensive. So use ultrasound whenever possible. Don't do X-ray to diagnose pleural effusion. Use ultrasound. That's safe. Number 8, use restraining device in children to prevent repeat. Make sure the restraining device, if there are devices that are on the machine, please make sure use them to limit radiation to that kid. Number 9, please protect the gonads. Gonad shield protection. Protect the gonads because they are very sensitive compared to other organs. Number 10, only necessary people should be present in a room where X-ray procedure are being performed. There are some patients like kids or other patients where the family member, they want to be in the room. Say, can I be there and see how you are doing things? And as a personnel who knows what's going on, you should not accept it. Please make sure the patient is exposed alone because there is a reason behind. Number 11, staff should wear lead apron. Lead apron, those protection from radiation. When you are operating, make sure you use them so that you are protected from radiation. Number 12, at no time should anyone other than the patient be irradiated directly from the beam. Even if you are in fluoroscopy, for example, I told you that in fluoroscopy, even the machine user can be within the room, the field of radiation. But make sure the primary beam is not orienting to you. Let it orient to the patient only. And number 13, all X-ray rooms should have lead lining in their walls, ceilings, and floors. That one, it is done. You cannot start using an X-ray machine without having this lead lining from ceilings, walls, and floors. Those are things we going with RLA principle in radiology. I want just you to know all of this so that when you come to radiology, you know the reason why this is done this way, this is not done. So, yeah. The next slide about now, I told you different modalities have different levels of radiation. From conventional radiology, like chest X-ray, there is an estimated amount, effective dose of millisieverts they can give radiation to the patient. Going to mammogram, you can see dental X-ray, different modalities can send different level of radiation. That one, CT scan give more radiation than convention than mammography. That one, I am not going into details. The same. From nuclear medicine, there is estimation of how much this procedure can give radiation, how much radiation can give to patient. There is that estimation. This one, every personnel in radiology should know it and have it so that he knows, even if I'm going, even a clinician should know that, let me send to CT scan, patient to CT scan. You should know, how much am I going to expose this patient to radiation? Okay. Have just an idea, just estimation. Okay. Question then. Question, any question? Navuze nihuta cyane ariko nari nzi ko byoroshye kuruta wenda bya I hope nkubajije ngo what is radiation risk, what is radiation protection, wambwira. Munyamakuru akubajije wa televiziyo tukureba twese nimugoroba makuru wavuga neza. All right? Cyangwa wagiminwa. Charlotte.
Yego, Prof.
mbwira izina ry'undi mukobwa mubaze. Mutari kumwe iribagiza, ambwiye ngo iribagiza.
Oya, Divine.
Aha, Divine.
W'ababyeyi.
Divine
W'ababyeyi.
Divine umubyeyi w'ababyeyi.
lecture.
Divine w'ababyeyi. Uranyumva? Divine?
Yes, lecture.
Aha. So tell me in summary, in few words, what is radiation protection? What is radiation risk? Ndi umunyamakuru ndakubajije hanze kuri televiziyo kabisa mikro. Tubwire ni mu Kinyarwanda cyangwa mu rurimi mushaka simbizi. Nako kwanza tubwire numva ukuntu mbwira. What is radiation risk? What is radiation protection?
Okay, I'm going to use Kinyarwanda.
Cyane rwose.
Twabonye ko radiation risk na radiation protection kugira ngo byubahirizwe ari principle yitwa alala aho
kutangiriye inyuma.
Okay.
What is it kwanza? Radiation ni iki kwanza, iva hehe ni ibiki?
Twabonye ko dufite different modalities za radiology, harimo CT scan, twabonye ko hari MRI, twabonye nanone ko hari
MRI nayo irimo. MRI nayo irimo si?
Okay, twabonye ultrasound.
Ultrasound nayo irimo si? Nkayange. Ko bikomeye.
Okay, nshobora kuba ntabyumvise neza.
Ntacyo uvuga ibyo gusa.
Twabonye ko izo different modalities zigira na dose zitandukanye za radiation
ariko MRI na ultrasound ntabwo birimo, bivanemo kwanza.
Yego, ubwo ndabimenye. Rero izo dose uko umuntu aba exposed kuri zo bigira risk. Twabonye ko hari acute na chronic. Iyo umuntu aba exposed kuri dose nyinshi ashobora guhita agira acute injury, hanyuma ku muntu ubaye exposed kuri izo dose of radiation ho igihe kirekire akagenda aba exposed so many times ko ashobora kugenda agira damage gake gake akaba chronic. Twabonye rero ko hari kugira ngo izo radiation risk zigabanuke, hari radiation protection aho twabonye ko hari urugero nka gonad shield tone, hari shield abantu bambara kugira ngo barinde gonads kubera ko ziri more sensitive kuri radiation, cyane ba radiology kubera ko buri munsi baba bari constantly exposed to those radiations. Twabonye ko nanone hari ibintu bitandukanye tureba, urugero nka individual umuntu ugiye kuba exposed kuri izo radiation. Twabonye ko abana batoya baba bari more sensitive kuri radiation kubera ko baba bari gukura bitewe n'uko their cells of body ziba ziri
regenerating.
Yes. So rero umuntu ugiye gukorerwa iyo radiation tukanakonsidera risk afite. Twabonye ko nanone tuba tugomba kugabanya umubare w'abantu bagiye kujya muri room yaho radiation ikorerwa kugira ngo tugabanye umuntu ugiye kuba exposed kuri izo radiations. Nanone twabonye ko tugomba kugabanya igice cy'umubiri ugiye kuba exposed kuri radiation, aho tureba only the concerned part of the body akaba ariyo yonyine twe expose kuri izo radiations. Nanone twabonye uburyo twagabanya radiation risk ko hari icyo twita appropriate justification, cyane cyane aho bireba aba clinicians, aho clinicians akonsidera niba koko uwo murwayi akeneye undergoing that that x-ray cyangwa se niba hari ubundi buryo bwakoreshwa kugira ngo tugabanye exposure for those radiations. Nanone twabonye icyo bita careful optimization, aho bireba aba radiologist aho bagomba kwitonda bakakonstara alala principle kugira ngo bagabanye exposure, umuntu kuba yaba exposed kuri izo radiations. Aho twabonye nk'urugero n'ikintu emphasizinzeho cyane, aho tutagomba gukoresha MRI kugira ngo tudiagnosing peripheral effusion, ahubwo ko instead.
Akanumvise na gato kandi k'ingenzi cyane. You have to know which modalities uses ionizing radiation. Aho byakuyone nakubwiye ko MRI na ultrasound ntabwo bikoresha ionizing radiation. MRI ikoresha magnet, it's safe. Ultrasound ikoresha sound waves, safe. Others they use ionizing radiation at different levels. Aho niho byagucangiye siza waragiye kandi byoroshye kuko icyakabiri ntabwo ugeze utubwira the source of radiation. Buri muntu wese are exposed to radiation every day. We are exposed to what you call background radiation and medical radiation exposure. Ni ibintu bibiri wovuze kuri medical ariko nta kibazo, ariko kumenya ko hari na background radiation nkeya nta kibazo. Ibindi ariko bivuze neza ndumva mwabyumvise. Muri isomo ndangije uyu munsi munyumve neza. Ubundi mu bizamini nagendaga ntanga kera, ntabwo najyaga mbaza ibibazo mu isomo rya mbere, sinajyaga mbibaza. Ngiye gutegura utubazo twinshi nzababaza mu kizamini for this lecture kuri overview of medical imaging no kuri radiation protection, radiation risk. Ndategura utubazo twinshi kugira ngo ndebe ko mwabyumvise neza, ko mwabyumvise muzabitsinda neza. Ariko ngiye gutegura utubazo twinshi ariko duto ariko twinshi. So read it carefully, understand it mbere yuko mbabaza ibindi by'amayimaje. So rero ndumva turangije ahangaha. Mbashaka yuko muba a professional, knowledgeable and good medical doctor. Niyo mpamvu nabahaye isomo. Hanyuma ikindi rero, Dr. Louise niwe dukunda kwigisha radiology hamwe kuva kera. We yigisha kuri musculoskeletal and CNS imaging. Yarabibabwiye? Ntabwo yabasobanuriye. Hanyuma jewe nkigisha kuri chest and abdomen, kugira ngo tugerageze kukavaringa what you need to know. So iri somo mbahaye, it was just medical. Niyo mpamvu nabwiye ngo I was supposed to start by this the first day before even Louise or another doctor comes in, because this is just introduction, this is just overview of radiology before you go into details and know what is CNS imaging, what is MSK imaging, what is chest and abdomen. Like now we must really somehow overview. Nsigara kuba ikirero cyane kuba imaging of chest. Ngaho mumbwira ukuntu tuzayigare muri iminsi ifite rero mbere yuko mugenda, kuko ubu ngubu ntabwo natangira irindi mananiwe twavuze byinshi. Can we have time 2 hours tomorrow morning?
Yes.
Not from 9, from early, from because nyuma ya saa 4 nzaba mfite ibindi bintu bikomeye. Dutangiye saa 2 top ariko nkaba ntangiye tukageza saa 4 naba ndangije lecture imwe muri izo.
Yes.
Nta kibazo rwose.
Voilà, donc ejo saa 2 top nzaba ntangiye. Nibwo muzamudahari nzavuga jyenyine. Saa 2 nzaba ntangiye isomo, ndatangira kuri chest imaging, kandi it is very important ku masomo nigisha. Chest imaging umuntu atayizi ntabwo yazava mu wa gatatu ari mwazavamo. Ni handi giye mu bizamini ntanga muri mu byo ntanga image, ntanga ama image ya chest x-ray nkakubwira, cyangwa se abdominal x-ray ukabwira ukinterpreta kandi kivyo uri kubona nka ukabitsinda cyangwa gatsinda ugasubiramo. So chest ejo nzavugisha mu gitondo kuri chest imaging. Make sure you are there. Make sure you are there and from mwabonye online hari kitwaye se spam ntago ari bibi.
It's a good.
Voilà, ba Janet yari yayanze, but it's good, it's not bad.
kuri bamwe
So have a nice evening then. See you tomorrow morning at 8 exact.
See you.
See you.